I'm Dave Keeley, and I want to wish everybody good evening and welcome. Thank you for joining us tonight. We are excited to have all of you in person and on Facebook Live, joining this important event focused on successful efforts that are transforming the maternal continuum of care locally and regionally. 2 weeks ago, we took a close look at the key aspects of optimal prenatal care, labor and delivery care, and postpartum care. The skilled professionals gathered on the 16th represented all phases of maternal health care and discussed today's environment for bringing about policy, environment, and systems change to better assure equitable, accessible, and high-quality treatment for all women, especially those of color. Systemic inadequacies came to light during our first session, such as gaps and inadequacies in reimbursing services that should be standard care. For example, doula support and mental health access were two glaring examples. Maternal care team productivity pressures in the current fee-for-service, profit-driven environment were called out as adversely affecting quality of care. So tonight we welcome your presence and your audience participation as we discuss the way forward to achieve needed, meaningful change, remembering that in healthcare delivery improvement, a rising tide raises all boats. So I am Dr. Dave Keeley, and this is Dr. Doug Robinson. We serve as co-chairs of the Health Justice Committee for the Reimagining America Project here in Charlotte. To get us started, we're going to call on Reverend Rodney Sadler and Reverend Dr. Rodney Sadler and former Charlotte Mayor Jennifer Roberts, the co-founders of the Reimagining America Project, or RAP as we call it, to say a few words of welcome. The Reimagining America Project is a nonpartisan organization that got started in 2020 in the wake of the tragic death of George Floyd in our country. Dr. Sadler?
Thank you. And thank you all for being here. I'm Jennifer Roberts, and I also want to welcome you to Caldwell's Hope Hall. I go to church here at Caldwell, and we are so delighted to see this space used for great community events like the one tonight. So thank you all for being here. Tell your friends and neighbors that we do rent this out. I also got to say I love your t-shirt, March for Change, because that's how Rodney and I started the Reimagining America Project. We were marching for change. We met on the streets, Spadysford Road, right after the murder of George Floyd. And we walked along and we talked. And we looked at what was going on around us and said, we can't let this keep happening. It's not right. We can't let race continue to divide, polarize, demean, and separate the people in our country. And we didn't know what we were going to do, but we knew we wanted to do something different. We wanted to hear the voices of those who have not been heard for centuries, and to elevate those voices and to bring to the fore issues in our system that are infused with race. It's in the water, it's in the air, it's in every system. We wanted to bring attention to that through the voices of those who are experiencing it. And the Reimagining America Project was born, and it's still evolving. And Rodney has been an amazing partner with Union Presbyterian Seminary and all the amazing contacts that he has. And you can finish.
Thank you so much, Jennifer, for your vision, for your work on this. So the Reimagining America Project really is an attempt to do something different. We are not here to get rid of racism, a simple instance of a racist act, a simple expression of racial disparity in healthcare, environmental justice, or voting rights. We're here to say that if you are to solve racism in any area, you have to begin at the root of this issue. And the root of this issue is the concept of race itself. The concept that we're somehow or another fundamentally, ontologically, biologically, genetically different, and that those differences should relate to differences in the way that we're treated in society, and the opportunities that we receive, and the places where we should live and where we should go to school. No, we're here to say that we need to transform not just people, but systems in order to achieve the kind of America in which we all want to live. That's why we're called Reimagining America. We're here to reimagine what we should be like, to work to manifest that in the midst of the world. So I'm grateful for this event tonight. I'm grateful for the second follow-up conversation on maternal mortality. It devastates my heart to know that Black women suffer different consequences just having a baby than white women. It breaks my heart to know that the healthcare system does not treat us all equally or fairly. So how do we work towards that greater sense of justice and equality? Well, I guess I can't tell you, but I'm so pleased to have this panel here tonight that will help us to see the way forward. So grateful for you all being here. Thank you for being with us. And know that this work that we're doing, it's not our work, it's our work. We need each and every one that's here to begin to work towards that society that we want. Amen? You all want to see that kind of world come about? Well, then let's work together to make it so. God bless you all.
Thank you, Dr. Sadler and Mayor Roberts. So, to get us started, I want to say again that tonight's program represents a wonderful collaboration with the League of Women Voters of Charlotte Mecklenburg, the Coalition for Truth and Reconciliation, and Healthcare Justice North Carolina, who are represented in tonight's audience. This is a very important and timely societal issue, maternal morbidity and mortality. And as mentioned, we spent time 2 weeks ago delving into the disparities by race and seeking to highlight the bright spots in maternal health care where improvement is being realized. That event was video recorded, as will be tonight's session, and we invite you to view it on the RAP YouTube channel if you missed it live on January 16th. Tonight we will continue the discussion among expert panelists as we focus on policy, legislation, and advocacy directed towards sustainable change at the local, state, and national levels to improve maternal outcomes for Black women in particular. A few ground rules. Before we introduce tonight's moderator, I want to cover a few ground rules. Please silence your phones so that we can avoid that interruption. When you are moving around the room, avoid walking in front of our video setup so that we don't get in the way of the recording. I will serve as our timekeeper and will let our panelists know when we need to move on to the next question. Questions from the audience are encouraged. For in-person attendees, we ask you to use the paper available on your table. For our Facebook Live audience, please submit your questions at any time by typing them in the chat feature. Dr. Doug Robinson will manage questions in the Q&A with the help of Raquel Ward. We will respond to questions after we complete our planned discussion of the prepared questions developed by our RAP Health Justice Committee. Finally, a quick shout out. Along with our 3 collaborating organizations, I also want to give a shout out to the Monroe County Democracy Center for helping promote tonight's event. Once again, welcome everyone here in person and on Facebook Live. Now, Dr. Robinson will continue with our panel introductions.
Thanks, Dave. I have the honor of introducing our moderator and presenter and panelists for this evening. We have a terrific lineup of professionals that I'm so proud to have here tonight. First of all, Dr. Janisha Brown is a family medicine physician, hospitalist, and faculty member with Atrium Health Wake Forest School of Medicine. She's the founder and executive director of Birthright, a nonprofit organization focused on ending the Black maternal health crisis through community education and advocacy. Janisha is going to be our moderator and initial presenter for this evening. For our panelists, we're fortunate to have Belinda Pettiford here. Belinda's worked for over 35 years in public health and is currently the Chief of Women, Infant, and Community Wellness Section in the Division of Public Health of the North Carolina Department of Health and Human Services. She oversees the state's maternal health, family planning, preconception health, teen pregnancy prevention, sickle cell, and numerous other programs focused on equity and birth outcomes. Michaela Penix is the National Director of Community Mobilization and Partnerships for March of Dimes and has served previously as the March of Dimes North Carolina Director for Maternal and Infant Health, where she worked to support programs, policies, and legislation to support North Carolina families in having the healthiest birth outcomes possible. Finally, Dr. Kimberly Scott is the Assistant Health Director of the Population Health Division of Mecklenburg County Public Health Department, where she oversees the operation of the Public Health Department's offices of health equity, chronic disease policy and prevention, and violence prevention. So at this point, I'm going to turn it over to Dr. Janisha Brown.
Good evening, everyone. It is with great gratitude that I am up here. Just want to, again, thank the organizations that have allowed me to be the moderator tonight, particularly the Coalition for Truth and Reconciliation for allowing me to put my name in the hat for being the moderator, so really appreciate that, and also Healthcare Justice for NC, which I'm also a member of. And I just want to say again that if you did not see our first night, it was a great night. It was a lot that we unpacked there. There were some great community organizations represented. I see some of them in the crowd tonight. We had mental health professionals, doulas, lactation consultants, and physicians all working together, talking about the things that we are doing to try to address this issue in Mecklenburg County. So if you did not get a chance to see that, please take a look. It's on YouTube, and it's also on the Reimagining America Project website as well. Also to our panelists, we have an amazing expert panel here. Thank you all for being here tonight. And hopefully we will have a really good deep dive into this topic. And I definitely want to encourage you all to feel free to do a second. If there's a question that goes to one person, hopefully we'll have time for additional comments, so feel free to do that as well. Just let me know. And we will also, like it was said before, please write your questions down. We want to hear what questions you all have for us as we go through the rest of the panel tonight. So without further ado, let's start with you, Kimberly. Let's talk about some of your work that you have been doing in the community. One of the things that we talked about in the first night, when we say the word access, we often think about someone not having insurance or not being able to make it to a healthcare center for care. But when we expand that term out a little bit more, broader than just not having insurance, there's a different view that we get. And it also shines light on some of the inequities in the broader sense of understanding how it can attribute to maternal health disparities. Can you speak on that a little bit?
Certainly. Can you hear me? Okay. Thank you so much, first of all, for the opportunity to represent Mecklenburg County Public Health. When we think about access, insurance is not the golden ticket. We are so excited that North Carolina has expanded Medicaid, but we also know that insurance is not the end-all be-all when thinking about access. Access to insurance also does not ensure that you'll have access to a provider, because many of our insurances may not be quality where they provide opportunities to see the providers that one might want to see. There might also be some just limitations regarding what's available within those service realms and cost overall. We know that insurance only covers a portion of the expenses. The cost to have children in this country has continuously risen over the years. I think Kaiser has some data that shows that in the United States, on average, it costs about $19,000 to deliver a child and experience those postpartum visits that come with birth. So it is very expensive to have a child, and insurance does not cover all of those things. So thinking beyond just access to health insurance coverage, there are other things that impact access, from geography, just physically being able to access healthcare sites to make sure that people have access to those resources, and again, providers of choice. Transportation, especially working in our local public health system, we see this regularly, even with our services, clients who need things like immunizations or WIC appointments. It's very difficult for people to have access to transportation when you don't have a reliable vehicle or there's no bus route that can get you from point A to point B. Or with our growing community, the streets are not walkable at all. So just making sure that there are opportunities for people to physically access physical buildings and resources and spaces is an important contributor to access overall. And then, of course, racism is one big thing that impacts access overall. When thinking about my own experiences, I recall my first OBGYN appointment at the age of 19 and scheduling an appointment, really seeking out a Black provider and having a hard time finding someone that reflected who I was looking for, and having to go with a backup provider that accepted my insurance at the time, and one who did not welcome me when I came into the facility and made many assumptions about why I was there based on what I looked like. So all of those things, my experience is very trivial compared to many who look like me and share experiences like me, but all of those things compounded definitely impact how we experience and receive health within our community or health services, and definitely contribute to inequities when you're unable to access those particular services based on those barriers that all contribute to how we experience access. And there's so many other things, from operational hours. We typically operate on a 9-to-5 schedule, but if you're a working mother who's working 9 to 5, how can you access resources during those windows of time? So when we think about access, it's so much more than, yes, I have a health insurance card, but what's the next part after that? The then what? Can I truly make access or connections with these providers in order to have those particular services that you're in need of on that maternal health journey?
Yeah, I really appreciate that broader sense of what that term access really means. And like I shared in the first night and shared with some of the panelists before we came up today, one of the things that draws me to this work is my own personal experience of having a heart attack 10 days after having my second son. You think about someone who has an MD behind their name and is socioeconomically stable, and how these issues can still occur, even in that space. It really does help to inform that there has to be more than just talking about, access in the term of finances and things of that nature. So when we talk about barriers in general, Ms. Belindo, I'm going to go to you here. We're thinking about how we improve maternal health, how we address these barriers. And I know that in your work that you have done, you have really been a bridge to some of the community organizations and some of the governmental organizations that are working in this space, to understand and address these barriers that citizens might have. How, drawing from your history and your experience, how can these organizations work to understand the barriers that communities face, and how can they work together to solve them, to attempt to solve them?
That's an excellent question. And as stated, I've been doing this for quite a while. I'll tell people all the time I started in elementary school. But I have been doing it over 35 years. My first job with the state of North Carolina, because I started in a local health department, but my first job with the state of North Carolina is we had, and the state still has this program, what we call our Healthy Beginnings program. It's our minority infant mortality reduction program. And I was the first project director. And when we started this program, our first thought was we wanted to reach out to community-based organizations that had strong credibility in communities of color and give them some funds. We give funds to all types of people, and sometimes, sometimes we're giving funds out of the state office where it's dependent on how well you can write your grant application. And so what we were looking at early on was, let's start with some small capacity building grants, something that you don't take a lot of time to write, but it'll give you maybe $10,000 so you can do a year of planning and figure out who do you want to come to the table, and think through who can help you write the grant. Because we see all the time, or very frequently, I guess I shouldn't say all the time, frequently we see people that can write an amazing grant, but it doesn't mean they can reach the community. And so how do you merge the two together? Because ultimately you want to make sure the person that's writing the grant has that we are being as equitable as possible as we're looking at our systems. One of the things, hold it this way, can you hear now? Oh, thank you. You said church hold. Yes, I do know the church hold. And now I've lost my train of thought. Oh, it's okay, Michaela, it's okay, it'll come back in a
We're
second.
talking about equity. How to make it
Thank you.
equitable.
Equity. I think one of the other areas that we really try to focus on that really came to light during the COVID pandemic. So during the COVID pandemic, one of the things our department stood up, where I work, is we stood up a larger group around historically marginalized populations because we wanted to get the word out around COVID to individuals that may not normally get messages from our department or may not trust the messages they're getting. So we spent many months and days and weeks working to get that group in place, and we continued it. I mean, we had a meeting today with our historically marginalized populations team because this is the group where we share information, whether it's around maternal health, whether it's around reproductive health, whether it's still around COVID, so that we can get the word out to communities. And we really try to reach out to those individuals that have those trusted relationships in communities. So that has been one of the ways that we've tried to reach. The other way that we really have looked at through our department is how we distribute resources. Because typically when you work, you get funding out of our office and you get monies out of our office. Basically what we're saying is you need to spend the money and then we will repay you. And we realize that with many of our community entities, our community organizations, that doesn't work. Especially when you're not quite sure, you know, you hope you'll get it back in 30 days, but you don't always, we can't always guarantee that. So what we have started trying to figure out is how do we do advances on the front end so that people can have some startup resources, but also how do you do strengthen your partnerships, your collaborations. One of the areas that we have really stood up around maternal health, but specifically around perinatal health in general, is we started working on this in 2012, 2013. In 2014, we actually did a convening of individuals around the state, and we asked individuals with lived experience, whether you were a community person, whether you were a consumer, whether you were a provider, worked at a university, were in healthcare, we asked individuals to come together because in North Carolina, we had a lot going on, but we did not have a specific plan around how we're going to improve these issues. Everybody had their own silo, everyone was going in the direction that they felt was best for them, which was great in many respects, but it didn't mean that we all knew what the others were doing, and we were tripping over each other at times. But we also didn't have a plan. So we did convene people in 2014. We brought in individuals and said, hey, we want to develop a statewide perinatal health strategic plan. We wanted the plan to address improving maternal health, improving infant health, improving just the overall health of individuals of reproductive age, because that was the population we were working with. We were able to have that meeting in 2014. We started meeting with policymakers in 2015. And in 2016, the very first plan was released. And this was a plan that we met with members of the General Assembly. We met with private foundations and others because we wanted them to see that we pulled all these folks together, and it was two things we were wanting. One, we wanted a plan that if anyone in North Carolina wanted to know something that they can take and do in their community to address any of these issues, that they can pull it from the plan. They didn't have to reinvent the wheel. They could if they wanted to, but there was a plan already in place. The second thing we were really cognizant of is we wanted people to see themselves in the plan. And so we made the plan very fluid. We normally print a couple of copies, I keep a copy with me most of the time, but for the most part, we only keep it on the website. And the reason we do that is because at any point in time, if someone comes to us and say, hey, this issue was missing from the plan, you didn't include this area and we think it's really important from our community, we wanted the ability to be able to add it to the plan. So that is when we set up what we call our Perinatal Health Equity Collective. So right now we have, typically in our meetings, we have between 200 and 300 individuals. Since the pandemic, we've moved the meetings to virtual. which has been really helpful for people. But we've also stood up some work groups within that work. And one of our work groups that I think has taken the greatest leadership has been what we started calling it our community and consumer engagement work group. They renamed themselves Village to Village because they wanted to see the village. They said for them, it was around what was happening in the different communities and how could they address these issues in their villages. Our Village to Village group was their Village to Village because it's, you know, I say our, but it's the greater our, because we have tons and tons of partners doing this work. This past year wanted to take the plan on the road. So we actually went around the state of North Carolina, and I was one of those people who were able to get to all of the town hall meetings, but we did 6 in-person town hall meetings from one end of North Carolina to the other, and we did 6 virtual ones, because we wanted to give people the opportunity to give more feedback on the plan. And since then, we've seen probably an extra 50 or 60 people that have started being engaged in the work. But part of it has been around, they wanted to know where they could get funding and resources if they were interested in implementing the plan. They wanted to know about the resources that came out of our office. You know, when we issue a request for application for funding that comes out of our office, we have listservs that we let people know about it. We post it on our website. But if you don't know about that, there's a good chance that you won't know about the monies that are coming out. And whether these monies are addressing improving maternal health, improving infant health, reproductive health, any of those areas, we wanted to make sure that we were doing a better job of making those connections.
Right. That's wonderful. And honestly, I just realized that all 3 of you have done work within communities. You know, like you started at that level. I would love to hear you, Michaela, talk a little bit more about your work in the community, at the community level, and how that informs what you do now with the March of Dimes.
Sure. So good evening, everybody. I do want to just give everybody a little brief of March of Dimes, because I don't know if everybody knows who we are. So the March of Dimes is a national nonprofit. Can you hear me better now? My church hold, I gotta hold on. So we're a national nonprofit. We were founded in 1938 by a sitting president, so we are one of the only nonprofits that was founded by a sitting president, who is FDR. And if you all recall your history a little bit, you know, I'm a test user, I'm also an educator, so I'm gonna give you some facts. So FDR had a condition called polio, and he started our organization with the hopes and the dreams that we were gonna eradicate polio, right? So we used some of our tools at the time, social media, if you will, influencers at the time, which was AKA the radio. And we got celebrities and local or national radio personalities to encourage people to march their dimes to Washington, hence the name, right? To march their dimes to Washington to help us find the cure for polio. So one of the things that's interesting about March of Dimes is we are also a nonprofit that engaged communities from the beginning. And if you look at your dime, the only reason I know this is because I work for March of Dimes. FDR is on your dime as a way to honor the work. And so after finding the cure for polio, March of Dimes turned to find how we could support families in other ways. We were determined not to stop there, right? So we looked to how can we save more babies? Pregnancy, right? There are a lot of babies who are born preterm, babies who are born with birth defects, low birth weight. These are the leading causes of infant mortality. So how do we then turn to the community and say, collectively, we can do this, right? We can end preterm birth. We can save our babies from dying. And one of the other things that I really appreciate about the organization and learning the history is that we engaged communities everywhere. It didn't matter what you look like. If you pick up what I'm putting down, right? It didn't matter that you were black or brown. It didn't matter. All of our babies were dying from polio, from preterm birth, and from birth defects. We all collectively need to save our nation's babies. So March of Dimes for a long time has engaged communities at every level. And so my current role with March of Dimes, it is my job to further engage our communities. So I work with national service partners. Many of the Divine Nine are partners with us, so those are black fraternities and sororities. I work with FBLA, I work with the General Federation of Women's Clubs. A lot of these organizations, and I help mobilize them to do community programs across the country that will impact preterm birth and maternal mortality efforts in their communities.
That's beautiful. You all are all doing amazing, amazing work in the community. I just want to just give them a clap for just that work. Honestly, these are heavy lifts, and it's just amazing the work that you all are doing. I don't know if you all saw the statistics up before, but from 2017 to 2021, there were 1,200 women that passed away related to maternal care and pregnancy. And in that disparity, or in that number, there's a disparity there of Black women being 3 times more likely. In Mecklenburg County, there are, it's a worse disparity, 5 times more likely to pass away related to pregnancy. And what these numbers do not represent is the trickle-down effect that it has within the community. So as we're looking at this problem, we have to really broaden our lens from even just looking at Black maternal mortality and looking at the families and the communities that is affecting. And that's kind of where I want to segue to a little bit now, is talking about that trickle-down effect. And Kimberly, I'm going to go back to you with that. Can you talk more about how you've seen this disparity and in general, just maternal mortality in general also, how it affects communities in that trickle-down way?
Sure. So I'd first like to start by reflecting and sharing that from my perspective and what I've witnessed in my role within the public health system, it's much more than a trickle-down. It feels like a tsunami that's really impacting our community. When you think about the grief that families experience from losing family members, that's a tsunami. When you think about the economic impact on families that may have experienced extended hospital stays or lost time at work because of these experiences, that's a flood, that's a tsunami. When we think about just the trauma that comes along with those experiences and how those things are transferred into our day-to-day life, rebuilding that trust with the health system can be challenging. It can lead to fear of just going to the doctor if you're able to survive those experiences. So it's so much more than a trickling effect that impacts communities. Some of these effects can be immediate and extremely impactful and widespread. Again, just the trauma of it all. I think about our team who does a significant amount of work to focus on various trauma-informed trainings to help build our workforce, support our families who have had these experiences, to make sure that we are building on that resiliency that has allowed us to survive these experiences. I'm fortunate to be able to oversee our population health team, which includes one maternal and child health program, improving community outcomes for maternal and child health, which we are so grateful to the state for funding. And on that team, there's a variety of training and initiatives that focus on just that, releasing, trying to build upon opportunities to build resiliency based on the trauma that our families experience. Mecklenburg County Public Health has also recently implemented a new program called the HOPE program, which provides some extended support for women who are visiting our clinics who might be dealing with postpartum, who have survived these experiences or had other traumatic experiences, where they can engage with professional clinicians to provide that additional layer of support. So again, when thinking about just the ripple effect, it's so widespread beyond just the families that are impacted by these experiences. It can impact our entire families. It can impact how we operate. It should impact how we operate as a system for the better, but oftentimes that doesn't happen. So again, the trickle-down effect is so widespread and can impact us on so many levels. And again, it feels like, from my opinion, a tsunami when we really think about centering the trauma of those experiences.
Anyone else like to comment on that question? This effect that it creates in the community, how does it impact the community at large?
No, I mean, I think Kimberly did an excellent job in talking about it, because I think what we hear all the time is how stress impacts birth outcomes. And so anytime you're dealing with the fact that you don't feel like you're being treated well, you don't have early access to care, you don't have the resources you need to address the social determinants of health in your life, those non-medical drivers, that is stressful. And when you add stress to a pregnant individual, then that is just a perfect example of that could impact the birth outcome. And not just, the the birth outcome of the child, but also how it impacts the mother. One of the things that, you know, we've done in North Carolina is we delved deeper into our maternal mortality data. So in December of 2015, the General Assembly basically gave us permission to set up what we call our statewide maternal mortality review committee. So we have a committee now, our team staffs it, and they review every maternal death in the state. So when you're looking at data that comes from, the national data that comes out, many times that data is not the data that we've released out of North Carolina, because we typically don't release the data until the committee has reviewed it. Because we want the committee to say, to look at a couple of things. One, we want them to make a determination whether it was pregnancy related or pregnancy associated. You know, if it was pregnancy related, was it something about the pregnancy that actually caused the mom to actually, not to survive? Or was it just associated, meaning she was pregnant, or within a year being pregnant, she was in a car accident, or fell and broke her leg or something of that nature. So we really look at that level. The other thing that the committee is able to do is we are now documenting whether discrimination was part of it. So this is something new. The Centers for Disease Control and Prevention, they actually started, they fund our state, they fund most states in the country right now, as long as they can keep the money in Congress, they're funding the states. And basically what they ask us to do is to document the associated pregnancies or those that were pregnancy related, and to also document discrimination. And the other thing we document was whether it was preventable or not. So the first report we released was our data for 2014, 2016, and we, based on our committee's review, 70% of those deaths were preventable. We're in the process now, within the next month, of releasing the next report, which will be the data for 2018 and 2019, because it takes a while to get caught up on that. And even though I can't tell you what the percentage is, we're still seeing a high percentage that are preventable. And the committee makes determination as whether it was related to something that happened in the community. Was this provider related? Was this, the type of care she received? They're looking at all of those areas and making recommendations as to how communities can go back and address those issues, as well as how our office does it as well.
And I think the word that you use, Kimberly, that ripple effect, is really, the impactful word that you should use to really kind of see how those things layer on each other and how they can inform things that we can do better.
I just want to add maybe a community perspective too, is when we think of, we're talking about maternal mortality, but there's also a lot of near misses. So there are these people who have survived a near miss incident, right? And the impact that has on their families and their ability to trust their healthcare provider. So if you think about, I almost died, and I told you I was in pain and something was happening, and you didn't listen to me. Now I'm a survivor, but how does that translate to my family, right? We all know bad news travels way faster than good news. And as this bad news trickles out into the community, it continues the great divide between these vulnerable populations and the healthcare community, right? And so we create this mistrust. It continues and continues. And we think about the next pregnancy, or my friend who's now pregnant. I'm not gonna be like, yeah, girl, you should go to every single prenatal care appointment and have a smile. I'll be like, we need this and this. Now she's scared, right? And I tell my students, she's stressed. And I tell students and everybody who will listen, nobody goes to medical school with the idea that I'm gonna kill a black woman today, right? Like, they didn't spend all this money to do that. But over time, people do not become people. They become numbers, they become a checklist. And so it's important that we all, in all of our roles, continue to maintain humanity. Because a mistake is a mistake on your list as a provider, but it is a forever impact in the community, for that family, and for everyone who hears that story. So I think that too is some of the trickle-down effect, is the disparity and the mistrust that happens between communities of color and the medical field.
Yeah, I totally agree. Let's take that and flip it on this other side and talk about the things that we could do in a sense that can trickle up, let's say, instead of trickle down. what are some of the things that you all are doing at your different levels within this problem to hopefully make this disparity improved?
Sure. Well, I can start from a national perspective. So there are a lot of things you all can do, right? And I am never the one who is always the bearer of bad news. It's not all doom and gloom. There's a lot of empowerment and being a part of a movement that helps improve your community. So my March for Change shirt is one of those things. So March of Dimes has this Advocacy Day. We have a national one, which this year is going to be March 5th and 6th, where we encourage folks to come to Capitol Hill and talk to your legislators. Tell them what is important to you. And for both my state level work and my national work, what I hear a lot from congressional members is they don't hear from y'all. They're like, nobody told me this was important. I hear it on the news or I hear it from my colleagues, but hearing from constituents is important. So there's a federal event. I don't know that we're gonna have a state event this year, but there are often other ways that we can participate. There are task force groups, this village to village group, they are always welcoming members, and we always need to hear from our communities. So there's an opportunity for everybody to lend their voice. We always need people to please lend your feet, right? Please be there. But those are some of the opportunities we have. We also have a platform called Share Your Story at March of Dimes, which is an online platform where we encourage people to share what has happened to them in a safe community of others who may have experienced the same thing. But we do that so that none of this is silent. The way isms continue to exist is because they hide in the dark. And I tell my students it's like roaches. They're like roaches, right? They're cool in the dark and they can breed and have a good time. But as soon as you turn on the lights, they scatter, right? So that's what we have to do. We have to bring these things to the light. So we encourage everybody to tell your story. Imagine if Serena Williams or Beyonce hid their stories from the world. We would think that it only happens to people who look a certain way, have a certain income, but they were bold enough to share their stories. So it's important for all of us to share our stories, both on these national platforms, your state and local platforms.
Thank you. And I'll add to that, Kimberly mentioned the fact that we've expanded Medicaid in North Carolina. And that is something we should all be celebrating because we know that that is, yes, it is worth a celebration. It's taken us some time, and we're so happy that we're there. Because that's an opportunity for people who don't have health insurance to now be able to go to the doctor and not be stressed about how they're going to pay the bill. And we know that about half of our pregnancies in North Carolina are unintended. Doesn't mean they were unwanted, it just means at the time she got pregnant, she was not planning to be pregnant. Which may mean you don't do some things like your body ready, you don't take the vitamins, you've not been to an appointment to see your doctor to see if your body is ready. So we know that is part of it. One of the things that we are very excited about in North Carolina as we're looking at intendedness is that we do have legislation now that's been approved in North Carolina where pharmacists can dispense certain forms of contraception. And so we are working with our partners over at UNC School of Pharmacy. They have received some fundings from the Duke Endowment Foundation, and they are actually working to train pharmacists so that they can dispense certain hormonal methods of contraception. And as Kimberly was talking about earlier around when you can go and see, when you can go to the health department, most appointments are 9 to 5. If you think about your pharmacists in your community, their hours are much, they are much extended from other hours. So you really will have the opportunity. Those again are hormonal methods of contraception, and they are just for individuals 18 and older. So it was not for the adolescent population, but it is for the adult population. One of the other things is right now the goal is to get at least one pharmacist in each county in North Carolina up and running, and I think we're right at 50% right now, knowing that it will take some time to grow that. The other area that we've been working on through Medicaid especially has been around the Medicaid extension in the postpartum period. So before we even expanded Medicaid, about a year earlier, we had the opportunity in North Carolina that if an individual is pregnant and Medicaid is how they're paying for their pregnancy, basically it meant that they got Medicaid from the time they enrolled in Medicaid. 60 days after the pregnancy ended, their Medicaid ended. which meant during pregnancy, you identify all kinds of issues, high blood pressures, it could be your diabetes, it could be tons of things, but there was no more insurance. There was no way to cover it. In North Carolina, now we have the 12-month extension. So now basically from a time a person is pregnant until from the time that pregnancy ends, no matter the outcome of that pregnancy, for the next 12 months, that person has health insurance. So they have full Medicaid. It also means that it's not just covering Medicaid related to pregnancy. But let's say you are pregnant and you find out you need to have your finger operated on or something. That will be covered. It's because it doesn't have to be related to your pregnancy because it is full Medicaid. I think the other area that we really have looked at is how we're doing a better job with supportive services, like making sure we've got community health workers available in communities, that Medicaid now covers reimbursement for group prenatal care. For those of you who've never heard of group prenatal care, many times this is basically where a group of individuals come together for all of their appointments, which means they kind of set up their own support group, their own little support system, and they get all of their appointments at the same time. They're engaged in their appointments because they're all in one large room, getting education, getting to know each other, and actually having to take their blood pressures. They still have some private time with the providers, but they've established this support network that has really helped with reducing stress and letting them know they're not in this alone, that there's someone going down this path with them. The other area that we really are focused on is doula services. And I know some of you probably have heard of doulas, some of you may not have, but these are basically individuals that are providing support during pregnancy. And even in the delivery, that person that is actually helping to advocate and to support her when she goes to either the hospital or the birthing center to actually have her child. So those are just some of the other areas that we're looking at as we continue to move forward with the work.
So from the local perspective, one challenge that Mecklenburg County was facing is that we had so many different maternal and child health centered initiatives that were scattered throughout the public health department and even our county government at large. So one thing that we've been really focusing on as far as trickling up is thinking about how we eliminate those silos within our own agency. And I'm so glad to give a nod to my colleague, Dr. Elizabeth Portis, who is here tonight, who is representing public health and our county's prenatal to 3 initiatives that really focus on that coordination on a countywide scale. Not only focusing on the maternal and child health outcomes, but also thinking about education outcomes and how we can have healthy starts for our families. So we're really excited about that particular initiative, which is gaining traction. And it's not just a county initiative. We talked about the hour. It's an initiative that really focuses on internal coordination, but also coordinating with our system-wide partners throughout the county to make sure we have a shared agenda for how we tackle some of these issues. So we're really excited about that bucket of work and how it's transforming. In addition to that work, our team has recently implemented a community health worker initiative called A Guided Journey that focuses on providing support from perinatal experiences, really up through age 3 for a child, to provide that direct support through community health workers to support families, to make sure that those social determinant resources are accessible, to connect families to medical homes, and to just, again, eliminate some of those barriers and gaps and just opportunity that the system can sometimes present when it's an intimidating system to try to crack as an individual. So we're really excited about that program. We've seen a significant uptick in participation, and we deliver that program in partnership with the local agency Caring that many of you may be familiar with. So again, through that program, we employ a workforce of community health workers. So we have really, like Melinda mentioned, adopted the community health worker model and looked at opportunities to continue to train and develop that workforce, because we know the importance of hiring people that look like community, to engage with community, to have that level of impact. And I'm just so proud of the team that we're starting to put together that really understands and is entrenched in community, understands the day-to-day experiences, because they are neighbors of people who they're serving. So we're starting to see some significant impact in those spaces. Our Guided Journey program has community health workers who are also bilingual, so we also have opportunities to serve our Hispanic and Latino audiences that might be a part of those particular programs or services. As mentioned, there are several public health initiatives that are connected to this issue, from WIC, making sure that people have nutritional opportunities, to immunizations. There's a wealth of programs and services through our local public health department. Again, our commitment is figuring out how we can eliminate those silos, because we know there's so many entry points to interface with our system so that people can have an experience where they can get access to all those resources and supports that are necessary. One other thing that we've really been trying to focus on as a local public health department is making sure that we have access to accurate, timely data that really reflects our community. Because oftentimes we do have data that's only state level data, or it's county level data and it's 3 years old, and it's not readily available for us to make decisions in real time when, as mentioned before, there may be a tsunami happening within our community. So we have taken some significant strides to build our infrastructure, to be stronger stewards of data, and to get better access to information so that we can support our community served. One big thing that we've done is that we have an epidemiologist on our team who solely focuses on maternal and child health. And that's a significant stride because many public health departments have no epidemiologist at all. So we're really fortunate in that we have a maternal and child health center epidemiologist to make sure that we are assessing and analyzing data that we have access to. We are also really focused on how we can expand the data that we have access to. There is a framework called perinatal periods of risk that is often used to assess different periods throughout a pregnancy journey that might be at increased risk for adverse experiences. And if we implement the model with fidelity and look at our local data using this methodology, we can often identify periods within our community where our residents are at increased risk for experiencing adverse outcomes. And with that framework, there's also a listing of evidence-based interventions or approaches that we can take based on those areas where we might have some weaknesses. So our team has not yet implemented this. We're in the process of collecting the vital records data that's necessary to implement this process, but we know that having access to this information will be game-changing for us to really understand what's happening locally within the community and inform our decision-making. From the data perspective, because data is important, when we think about our population health and population served, we have to have the data so that we know who our population is and how we can serve them. So in that same vein, we're also looking at how we can expand access to our PRAMS data, which we partner with the state on to oversample, and this is basically a surveillance system that surveys pregnant postpartum women to understand their experiences and just collect additional data to understand what's happening within our communities. So we're really looking forward to the opportunity to oversample so that we can hopefully get some more representative samples to understand what's happening within our community. So we do have a variety of our traditional programs and services that are available through our public health department, but I wanted to uplift the intentional efforts to really think broadly about data and what it means to access data so that we can make informed decisions versus just doing things out of tradition or because we've always done it, to make sure that we're reaching those appropriate audiences.
Thank you all. Thank you so much for these insightful answers. Thank you all. We're actually going to go ahead and get ready to take some questions from the audience. But in the meantime, we do have a question that we wanted to ask all of you all, which is, what do you feel like is the next big step? There's a lot of initiatives happening at multi-levels, but if you could only choose one, what do you feel like is that next big step to really move the needle forward for Black maternal mortality? I stumped these amazing women. You gotta pick one. You gotta pick just one.
I'm gonna lean into my new national work. But what I think is really helpful is to train advocates. So when I say advocates, I do mean empowering individuals who are pregnant to know what to do when they get there. What we hear a lot is, I didn't know what I didn't know. I didn't know I needed to know all of this information. So helping make sure that patients are well educated. But in the incident that there is a near miss or there's a medical emergency, the person's partner or whoever their support person is may have to make some medical decisions. And they definitely don't know what's going on a lot of times, right? I don't know if any of y'all have fellas like that, but somebody is uninformed. They're like, I didn't even know she had breakfast this morning, right? Or it could be, you know, a mother or somebody. People just don't know what they don't know. So in my heart, I feel as though if we could make sure that folks were empowered, there was a toolkit to help make sure that everybody knew kind of a checklist of what I should be on the lookout for and how I can support my person, I think we could see a lot happen. But it also means, and I can't leave out the part that we also have to break down some stigmas in that, right? Working with Charles Johnson, if you remember his story about his wife Kira, who passed away from a childbirth-related incident, he says a lot of times when he saw the blood in her catheter that he didn't want to make a stink. He didn't want to make a big to-do there because he was afraid of being seen as an aggressive black man. So I'm afraid to speak up because it is not going to do my wife any good. If I get kicked out, then who's going to be here? So there's a lot of breaking down some of those stigmas and associations that we have and making sure that patients feel safe in expressing their concern.
Actually, I think you nailed that one, Michaela. I think while we're doing that, though, we still need work on building a strong and inclusive workforce. We've got to be able to feel comfortable with the individuals that are providing this care, you know, whether it's a physician, whether it's a midwife, whoever it is, we've got to feel comfortable with that. I serve on a national committee on the national level, the Secretary's Advisory Committee for Maternal and Infant Care, and one of the areas that we really have talked about was around race concordant care. And I think we spent a lot of time talking about race concordant care, but in our reality, that is a difficult thing to implement. And then more recently, just last week, I was in Washington, D.C. for a maternal health meeting, and we had an awesome panel of moms. It was just a panel of moms. And one of the moms, she stated something that really resonated with me from the standpoint of, I made a concerted effort to find a woman of color to be my OB because I thought I was going to have a better experience. And she said she didn't. So I think as we're thinking about race concordant cares, we're thinking about how moms are treated and really thinking about, I think about CDC, they lost one of their staff members who died from, had a maternal death. So from that, they started building and developed what they call the Hear Her campaign. And the Hear Her campaign really is about, we need to listen. And we don't need to listen to respond, we just need to listen. And then actually follow up on what she's saying. Most women will tell you when something doesn't feel quite right. So we should listen and be trying to follow up and not dismiss her. And I think that's been part of the challenge. We're really excited in North Carolina that during earlier, I think it was spring of 2023, now in North Carolina, our nurse midwives can practice under their full scope authority, where in the past, they had to practice under a specific physician that was directing and guiding their care. But for those that are, after they've had so many hours of experience, they are like many other nurse midwives around the country where they can practice based on how they were trained. And we already know that nurse midwives you will see where they are a group that will actually go to rural communities. They will spread out around the state to make sure that we've got really good coverage. We think that is one of the positives about that, realizing that there are others coming from it. But we do still need to make sure that any person that goes in feels like they are getting respectful care and they are being heard. And whatever that entails is what we need to do to go along with what Michaela's saying.
So I was going to say listen, but I'll take it a step further and say hold those accountable that don't listen. I think that we've gotten to a point globally where we really look at, diversity, equity, inclusion, racism, and training centered in bias as a check mark, instead of really thinking about how we can implement these things as tools for change. So really moving beyond, we're doing this just to do it, and thinking about the why behind it and holding people accountable for not, following in accordance with those things. I grew up in a very rural community in Georgia and lived in some very rural communities, and I've been in healthcare facilities where Black patients were scheduled one day and other patients were scheduled on other days. So these are very real experiences where you can't train your way out of a box and say, oh, we've had this opportunity to train and now we've solved this issue. There's some deep-rooted cultural experiences that we have to really shed light on and think about what it means to be accountable in these spaces to make real change. So in addition to listening, I'll add that layer of accountability for how we really move forward with addressing these issues.
Absolutely. Thank you all so much for those answers. All right, so we have some questions from the audience, and one of them, actually a couple of them, we have some amazing questions from the audience. Hopefully we can get through as many as possible. So a couple of questions. Oh, yay. A couple of questions, wanted to touch on a point that we did not get to, talking about legislation at the national level, but then also at the state level. I know we wanted to touch on the Omnibus Act and talking a little bit about that, but really they want to know what legislation specifically is there that is at the federal and state level to improve Black maternal health, and also how, I think we touched on that a little bit, how they can advocate for it. Anybody want to take that one?
So the Omnibus is a very, it's 2 years in the making. We're on year number 3. It doesn't have a lot of traction in Congress, but it has a lot of traction in the news. So that's also wonderful. So the Omnibus touches on a number of social drivers of health and programs that will trickle down to the state level that really will support the state health department and then to your local health department and other entities in having the funding that they need to implement things in our communities. But if I had to pick out some pieces of legislation, put back on my state hat for a minute, that are important, I would say we have accomplished a lot in the last few years with Medicaid expansion, making sure we have postpartum Medicaid extension, as Belinda mentioned, and the full scope authority, which addresses things like maternity care deserts that we have in our state. And if you didn't know, about 40 of our 40 counties out of 100, people don't have maternity care services available nearby. There are some counties where they have to go a county over. And especially the northeastern part of our state, some of those good folks go into Virginia for their care, right? You shouldn't have to drive that far for maternity care. So some of the legislation that we talked about addresses some of that. But we still have work to do in terms of paid parental leave, right? I saw, TikTok teaches us a lot, but I saw somebody do some street interviews, and they asked folks, how many weeks do you get for maternity leave? And people said, oh, maybe was it 6 weeks? Is it 12 weeks? And in the United States, it's 0. It is 0. Nobody has to provide you maternity leave here, or parental leave, right? Dad should be able to stay at home and bond too. So that's something that we need to see happen across the country, and especially in North Carolina too. But to take it a step further, we do not have paid sick leave in our country. That is not a requirement. So if we think about preconception, right, before someone ever gets pregnant, nobody magically becomes healthy because they're pregnant, right? Just because I'm pregnant doesn't mean that my diabetes goes away or that my hypertension went away. Folks should be able to access health care before, during, and after pregnancy. And in addition, I shouldn't have to make the decision to go to work and get a check or, take care of my health. And for me, that's a little personal because after graduate school, we were in a recession. I had this new diagnosis of diabetes, and the YMCA, the position I had, it was rough, y'all, built character. but I didn't have any paid sick leave. So here I am with this new diagnosis of diabetes, and broke, right? I'm broke. I'm emphasize I was broke. How am I gotta make a decision. I gotta make a decision with this hourly job. Am I gonna go into the community health center, which praise God for them, were there to provide care for me because I had no health insurance. But I also got a light bill to pay, and how am I gonna eat? And if I miss work, I don't have a check. Like, that's money that's gone. And so in this position, I think about those decisions that people have to make. And no one should be forced to decide whether I can have lights and food on the table or I can take care of my health. So these are pieces of legislation that we need to make sure are passed to support the health of everyone, but especially our birthing communities. And just to take it a step further, we don't have workplace accommodations either for folks who are pregnant or postpartum. So imagine, we hear a lot about the Walmart workers where they're pregnant, they have to stand up, or they could get fired if they don't stand for their shift. And I can't imagine being 40 weeks pregnant and having to stand up for 8 to 12 hours, right? Or have some kind of disciplinary action because I need to go to the bathroom. There's a baby sitting on my bladder, right? So these are common sense pieces of legislation that we need to see at a federal level and also at a state level.
I think another question made a nod to the impact that universal health care, like Medicare for All, would have on the disparity in maternal health, and also as we compare ourselves nationally to other, well-resourced countries, as just a common sense, understanding of what that could do and how it could impact the baseline of maternal health in America. All right, ready for another question from the audience? Here is a good, I'm just going in order. I hope we can get to all the questions, but do you foresee hospitals becoming more welcoming to doulas being present and not counting the doulas as visitors in the future?
That's my question. Excellent question, and I will say that there are conversations going on to that effect. We actually hosted a meeting a couple of months in December. Oh, wasn't a couple of months ago. Last month in December, we hosted a meeting with individuals with healthcare systems and individuals and payers and funders to try to understand what some of the challenges were around making sure doulas were welcome into the healthcare setting. And one of the things that we found out is what really brought this to life was during the pandemic. So during the pandemic, many of you probably remember where they limited who could come into the hospital. So there were hospitals, we were told, that that the person had to decide your doula could come or your mom could come. And so you're thinking, well, what kind of decision is that? And so the goal right now is to work with healthcare systems so that they can understand the role of a doula, continue our dialogue and conversations around doulas. During the last session of the North Carolina General Assembly, one of the things that did not get approved in the budget was Medicaid reimbursement for doula services. We anticipate it may come back up during short session, we don't know. But one of those areas is if you want a doula, the mindset is you should be able to get a doula. And it should be because you cannot afford one. It should be because there's a way that it can be covered by Medicaid. So I know that our partners and our sister agency, our Division of Health Benefits, this has been one of their priorities for the last several years, and we work very closely with them on it, so we're hoping that will move forward. So the short answer is yes, I do think they will become more opening to it. I just think it will take time and conversations to try to make sure we're all on the same page.
To add a brief comment to the doula discussion, one thing that I am proud of for Mecklenburg County as a whole is the use of the ARPA dollars, the American Rescue Plan Act through COVID, to support expanded access to training for local doulas. So we'll shout out to our partners from Johnson C. Smith. But this has been a great opportunity to expand the workforce, and I think that's an important part of advocacy, building the workforce and advocating and uplifting the voices of those who are working in those spaces. So I wanted to uplift that from a strategic perspective doulas have been central from a county perspective to the conversation and thinking about how we can continue to edify and build that workforce and make those investments.
Wonderful. All right, are any of you aware of bias training medical providers may have access to? And could the lack of training on bias and its effect, I guess, on maternal health be the cause of Black women's high maternal rates? And I think we also touched on this a little bit in the first night, so, but.
Mr. Martin actually has the training.
So March of Dimes does have an implicit bias training. We developed this training a few years ago. North Carolina and the State Health Department were champions in helping us establish that widely across the state. So it's a national training, and we go through implicit bias and how it impacts maternal health. And we'll take a dive through some historical perspectives and make sure we all have shared definitions. Part of the reason some biases live is because we don't have a clear definition, so we're gonna make sure everybody knows what this is and what the definitions are. And we have been blessed to have good partners to make sure this training is available to healthcare providers across the state. Most recently, Blue Cross and Blue Shield of North Carolina provided funding for us to give 30 of these trainings across the state. We have 9 that are coming up in February. They are free. You are welcome to attend, and I'll make sure that our organizers have that information to share. But if you are a person who needs continuing education credits, so nursing education credits or CMEs for your medical credits, we do provide those. So please take advantage of those training opportunities. And again, they're around the country. Not all of them are free, but I'm very grateful that Blue Cross and Blue Shield of North Carolina invested to make sure we could provide these for free to all of you across the state.
And I will add that even though it's not specific implicit bias training, what we have been doing is partnering with the area health education centers, the AHECs, where they have their scholars program. And so their scholars program is typically freshmen and sophomores in college, but sometimes they'll do juniors and seniors in high school. And the purpose of the program is really to try, from our perspective, is to try to make sure we're using it as an opportunity to diversify the workforce. So typically these are Black and brown individuals, and we're trying to expose them to the subject matter of maternal health. So as they're going through school and trying to make a decision as to what they want to do next, that maternal health may be one of their options. All right. Here we, you can, do you have, okay. So how can houses of faith collaborate with you all and help raise awareness for Black maternal mortality?
Let's start with this question. So interestingly, this has increasingly become a question that our partners have posed to us. On our population health team, we have a program called Village Heartbeat that engages a network of faith leaders and communities throughout Mecklenburg County, primarily serving our African American communities. So we are currently in the process of strategizing how we can continue to partner together to tackle some of these issues. One thing that's been an immediate area of interest has been providing space for breastfeeding friendly spaces for families within faith communities. So our team has been helping research and identify opportunities to outfit spaces within these centers so that people have access to safe spaces for lactation support. But additionally, I think there's significant opportunity to expand partnerships in that space. Our team also provides community grants to faith organizations who are engaged through this network, and we have diversified what our funding looks like to be able to support our faith network. Historically, we focused solely on chronic disease prevention initiatives, but we've taken it a step further to align with our broader countywide community health assessment, which includes maternal and child health as one of our priority areas of focus. So we've been really thinking strategically about how we can provide increased funding opportunities to support our faith networks and also continue to build upon some of these existing strategies that are really rooted in educational support and lactation support for families that are attending those facilities.
And we also open up our funding, so I know we're funding right now 2 faith-based organizations that are implementing our Healthy Beginnings program, our Minority Infant Mortality Reduction Program. And as part of one of our federal Healthy Start programs, we actually develop a Ministry of Health curriculum around maternal and child health to actually look at ways that local faith entities could take the information and use it in their own houses of worship, you know, how they actually wanted to implement it. So it could be whether they were doing baby showers, whether they were offering to provide transportation for individuals that had challenges with transportation. We had some that were doing some peer pieces, you know, connecting, like a mentoring process. So I think, you know, it really just depends on what the faith entity wants to do. Because I think between the local health department, state, national, I think there are opportunities there. And sometimes those opportunities come with funding, which makes it really nice.
All right. So what does the state of North Carolina, or excuse me, where does the state of North Carolina statistically fall compared to national Black maternal death rates? And why is Mecklenburg County's rate so much higher than the national Black maternal death rate?
Well, I probably should have looked that up before I came. I think one of the things, I think 2 things. One is there's 2 sets of data when you're talking about maternal mortality. As I stated earlier, we typically don't release it out of the state health department until the data has been reviewed by Maternal Mortality Review Committee. And one of the reasons we do that is we did a quality improvement project, and we found out that when you're looking at some of the data, it's based on whether on the death certificate if the pregnancy checkbox was checked or not. We did a QI project and found out that there were some men in North Carolina that had been having babies that we missed on. So we were like, we need to delve a little bit deeper into this and make sure we're not just relying solely on the checkbox. And so that's why we tend to release the data after the committee has reviewed it, because that means we've got medical records from providers, we've gotten records from all types of places to really delve deeper and to pull out what those causes was, what was going on in that person's life leading up to the pregnancy, while she was pregnant, and even up to a year afterwards, depending on when she may have passed. So that was one of the areas. I will say when we used our data and looked at our most recent data, our disparities had improved based on that data. That data is different from the national data that may be reported for North Carolina, because that's going to be based on the pregnancy checkbox. And so I don't know which data you were looking at for Mecklenburg, because we typically don't release it by county. And one of the reasons we don't release it by county is that even though one death is one death too many, our numbers are still relatively small. And so we don't release it by county out of our office because we don't want it to be attached back to a family. We don't want a family to say, well, you've been looking at our data and now it's all out there for everyone else. Because some people, you know, it's a very personal issue. It's very private and people may not want to share. So we release aggregate data with it all pulled together. At times we may release it by one of our 6 perinatal care regions in our state, but we don't release it by county, not 1-year data.
I was just going to echo that point, that our data, we usually look at it at 5-year spans for that reason. So we typically don't release 1-year data for maternal mortality data specifically, and infant mortality data as well. But I did want to uplift again the perinatal periods of risk model that was referenced. I think once we employ that strategy, we will be able to take a deeper dive and look at what's happening locally in the community and understand which periods we are at greater risk. So we do intend, once we implement that model, to make data available. We're really centered on data democracy, so making sure that we have opportunities and spaces for people to review information and make informed decisions based on those resources.
Do we have time for a few more questions? 2 more, okay. All right, so this question is talking about how can we get Medicaid, in your opinion, to cover prenatal lactation visits for pregnant persons that do not have access to OB offices that have patient-centered care?
guess I'm the only one up here that works for the state of North Carolina. I really need to look into that a little bit more, because I know Medicaid covers some areas of it. They may not cover everything that everyone wants. And typically, Medicaid will cover it if they can get the state resources. Because the way Medicaid works is typically if the General Assembly gives them state dollars, they have a pot of state monies, and then they can match it with the federal dollars and get permission from the Centers for Medicare and Medicaid to cover something, if it is an area that is already approved to be covered. So if it's an area that's not covered, I can connect you with someone with our state Medicaid office, so we can talk about it or try to figure out exactly what you think is missing that is still needed versus what is already out there that is being covered. But it may really just be it may really boil down to they may not have the resources to do it.
This is our last question. We did have a couple of more we didn't get to, but if you are maybe able to stay behind and ask specific panelists the question that we didn't get to, I'm sure they'd be happy to do that. This last question will probably even need some more discussion too, but what do you think will be the effect of the current 12-week abortion ban on maternal morbidity, mortality, and outcomes for maternal health?
Excellent question. I don't think we actually know yet in North Carolina. We are at a 12-week is our limit on abortions in our state. And so I think what we continue to do is look at data. So we will continue to look at our maternal mortality data. We'll continue to look at our severe maternal morbidity, or those near misses that Michaela was referring to, just to see if we see any changes. I don't think we'll see, if we see changes, I don't think it will be immediate, because the data doesn't come immediate, so it may take a little while. But in reality, I think what we have chose to focus on are a couple of areas. One is around, in the same bill that actually limited access to reproductive health in our state, that same bill provided some dollars that could go, I think it's $3.5 million, that only local health departments and community health centers could apply for. And those funds could be used to increase access to contraceptive services, as well as improve maternal and infant health. And so one of the areas that we did put in the request for applications when we released it to those entities was to say, if you're offering reproductive health services, let's say you're offering contraceptive services in your agency, you can get these dollars if you choose to either extend your hours, so it cannot be your 9 to 5, it needed to be able to extend the hours, could be Saturday morning or whatever, or you set up a secondary location to maybe get closer into the community, especially communities that have very few people, very few places that they can go to. So we have focused on that. I think the other area that we really are looking at is around preconception health, and how we can make sure that with Medicaid expansion and some of the other areas that individuals are realizing that they may qualify for Medicaid. I mean, one of the things we keep asking everyone to do is talk to your family and friends and let them know that we have expanded Medicaid in North Carolina. In North Carolina, on December 1st, which is the day we officially, Medicaid expansion went into effect, nearly 300,000 people that were already on family planning Medicaid moved directly into full Medicaid, realizing that that is a much more comprehensive form of Medicaid, so that was important to us.
Wonderful. Well, thank you all so much. Let's give our panelists a round of applause. Great discussion. Thank you all for your insightful comments, and really appreciate the level of work that went into even just answering those questions. So thank you so much. We're going to pass it over here. Yes.
Yes. Thank you, Dr. Brown. Wonderful job, and thank you to our wonderful, very talented and experienced panelists for your contributions and taking your time to be here in person and really testify for what's needed when it comes to legislation, policy, and action. We've endeavored to shed light on encouraging positive change as efforts proceed to transform the maternal continuum of care through addressing the key legislative policy and advocacy opportunities for making systematic and systems improvements, especially those issues that affect Black maternal health. We appreciate your attention here in the hall and online, and your input along the way. We want to now encourage everyone to study the resources listing and the taking action list. On your table, there's a 3-page handout, and we have put together a very extensive list of resources, and the committee has put our heads together, and we have some taking action steps that we would recommend. So please, take note. We have this handout that will be available and posted on the RAP website and on Facebook. Along with the handout, you will also, as we mentioned, be able to access our video recording from tonight's program. It'll be on the Reimagining America Project's YouTube channel and Facebook page. And tonight's PowerPoint slides will also be posted on the website. At this time, we'd like to dedicate tonight's program Many of you have heard the name Marion Sims, maybe not. Marion Sims was an early American physician who actually had some roots in Lancaster County. And we are calling attention to Anarcha Westcott tonight, who was a enslaved woman and who experienced experimental GYN, OBGYN practices that were part of Dr. Sims's practice. So calling attention to our history is something that the Reimagining America Project is very much about, and so tonight we want to dedicate all of the efforts that have gone into this presentation to raising awareness of some of the suffering and really unjust activities that are a part of our American history. To help us navigate our way forward with our health justice efforts, we ask you all to please complete our audience post-event survey, which will take less than 5 minutes of your time. For those of you here in the hall, on your table, we have a simple handout with the QR code that will take you to the survey. And for our online viewers, make sure that you take an opportunity to view the link that we have now showing on the slides, and that way you can access the post-event survey. In closing, we hope that you have come away with valuable information to enable your own grassroots advocacy on the key public policy and legislative initiative areas that we've highlighted. If you would like to become a part of RAP's ongoing health justice efforts, please indicate your interest on the post-event survey. Once again, let's have a round of applause for our moderator and panelists. And I wish you a very good night. Thank you. Oh.
And that is that Reimagining America. Oh, thank you. We're having problems with the on-off tonight. The Reimagining America Project also has a program Thursday night at Catawba College in Salisbury. So if that's not too far away for you all, it's about climate and environmental justice, which, by the way, impacts maternal Black health, because we know that Black and brown communities live in communities that have worse air quality, worse water quality, near highways, fewer trees. Environmental health is also a contributor to the challenges our Black mothers are seeing. So we're gonna, we have Jamal Black with the Salisbury Rowan NAACP, Edgar Miller with the Yadkin Riverkeeper, yours truly, Jeffrey Robbins, Executive Director of Clean Air NC, and Mercedes Casada Embid, who's a professor at Catawba. And that is at 6:30, and these flyers are all over the place. We hope to see some of you there as well. Thank you so much. I don't know about you, but that painting of that poor woman with all those white men looking at her, that hurt. That hurt. And I am just so glad that more people are working to change the history we have. Thank you all so much. Thank you.
Thank you, Mayor Roberts. And once again, let's keep the efforts going. Let's educate ourselves, be advocates, and again, I'll invite you to get involved with the Reimagining America Project and just visit the website and you can learn more and get involved. Thanks again. Good night.
Thanks.